So, thank you for inviting me here today. I'm a neurologist and a headache and facial pain subspecialist. Yes, there is such a thing out there. And I see a lot of your patients for trigeminal neuralgia, concussions, and then a lot of headache disorders. This talk is a new one for us, and I want this to be completely new for all of you. Most of your neurology colleagues aren't going to see or won't know some of this data because it's so new. Literally, I was waiting to the last minute to get certain slides approved so that I could present them here today. So if 90% of what you hear is new to you, that would be my initial goal. I'm going to briefly talk about some mechanisms of migraine and cluster, more so that you can understand the therapies and how they relate. We'll talk really briefly about current therapies, but really the focus again are on new therapies and emerging therapies. So let's start with a construct that we all universally agree on. So headaches are very difficult to deal with. And for those of you who manage patients with headaches, I mean, you know they're out there. But this is actually, didn't show it, but this is actually a very exciting time in headache. There has been a lot of revolution in the science of headache that we haven't had before, and we are changing the way we think about the physiology of headache, which is some of the things that we'll talk about today. I want this to be very personal for you, so you know you have headache patients. They're out there. You see them complain to you and call you and leave messages and so forth. But I want you to look at this perspective from a patient's perspective. Many of us here in this audience probably have migraine. If we don't, we're married to someone. And if we don't, we have kids or parents that have migraine. Are there any people in this audience that have no immediate family member with headache disorder? Okay, looks like maybe 20% of you. That's about what I figured. So 12 to 18% of Americans suffer from migraine, so a much higher percentage here in this audience, obviously, than in the general population. About 1% of patients have cluster. So let's look at concepts of pathophysiology. So I say concepts because when we look at pathophysiology or the science that we've had for the last 20 years, it's a mess. It's all over the place. You can always tell the neurosurgical kids early because they go and they get the blocks, put them together and say, what did I build? The neurology kids will count all the blocks, count it a couple more times, and then start counting the ceiling tiles. So we have a lot of different concepts, but we haven't put them together. I'm going to try to put them together in some reasonable fashion for all of us to understand. So this is one of the early studies in fMRI, bold imaging, that was done by my mentor at the Mayo Clinic, Mike Rucher. And this looked at a concept of cortical spreading depression. So since the 1940s, we've understood from Liao's study that there is this excitatory electrical wave followed by electrographic decrement with spreading depression in migraine. This is where we get the aura from. This bold study actually showed that this electrical wave starts or initiates, and it's followed by decreased blood flow in that same area that corresponds anatomically to the visual aura described by patients. Is this how migraines start? Question mark. Is this why some of our traumatic brain injury patients, if we hit the cortex of the head from an injury, is this what we're seeing? Is this why we're getting migraine-like symptoms? Question mark. So let's think about this construct as one. And then let's go into this other construct. So we also know that the trigeminal vascular system is a main component of headaches. Is it independent or is it initiated by this cortical spreading depression? Question mark. So most of us think of the trigeminal nerve as being an efferent nerve. It receives symptoms. You scratch your face, sensory symptoms come into the brain. But we've all thought that there is also some efferent version of this. And so what we do know is that the onset of migraine, this peripheral nerve releases some chemical peptides, including CTRP, which I'll get to, substance P, and initiates an inflammatory cascade in the vasculature. Now, it is likely a loop. So we all think of the problem as a linear problem. If you start A here, you get B there. But what if it goes back and forth? So could vascular manipulation initiate CTRP release? Question mark. So there may be a back and forth, and some of the studies have shown that. So basically the idea is this nerve that wraps around the brain and wraps around the skull, it initiates a signal that starts inflammation in the blood vessels, an inflammatory cascade. This is what gives you the constriction and dilatation, which is probably not the core of why we experience pain, but just a function of it. This sensory input comes in here and down to the brainstem and goes down to the trigeminal cervical complex. So this headache center at the base of the brain, the base of the brainstem, the top of the cervical spine, hence why you might get some pain in the occiput. And then the signal is brought into the thalamus and into the sensory cortex. So look, we're going to just use this as a construct, maybe as a way of thinking about the problem. Could a signal in the brainstem initiate this? Yes. Could a signal in the periphery initiate this? Yes. Could the cortical spreading depression initiate this? So let's start with a question. The hypothalamus is not related to which headache? All right. So, two of these headaches you've probably never heard of before. So we've kind of talked about cluster headache earlier today as it relates to DBS, which is fantastic, and this is something that we've been waiting for a very long time. It has sister disorders, paroxysmal hemicrania and SUNT. So cluster headache is this sudden stabbing pain that lasts 45 minutes to an hour and a half, middle of the night, makes you tear, makes your eye droopy. It's always one-sided. This is the headache where people actually commit suicide because this symptom is so bad. Well, there's actually worse cousins of this headache. So paroxysmal hemicrania is 20-minute intervals 5 times in a day or more. SUNT is 200 of these jabs in the middle of the day. And so we've got these sister disorders, and we've learned that the ipsilateral hypothalamus seems to be involved as per our fMRI studies that have been done over the past 20 years. But in all of these patients, we see the same signal. So could future DBS in this area assist with all 3 of these disorders? And I would ask the future neurosurgeons who are going to do these procedures, think of this as a family of disorders because we have a lot of different headache disorders that would benefit from such a procedure. So existing therapies, we do have some. Topiramate, Depakote. We don't really use Keppra a whole lot. A lot of the blood pressure medications, and these all work. But what do we know about all these meds? None of these meds were designed for headache. They were all designed for something else, and oops, by the way, we see a benefit for headache. One of the medications I did not put up that kind of ties in with the prior discussion of Alzheimer's is Memantine. So Namenda is actually a therapy that does work in certain patients in terms of reducing migraine headaches. But these are oral therapies. Is anyone on any of these medications? Or I'm sure most of you are familiar with at least some of these meds. And what you know is that these are very heavy medications for the most part. Who knows who this guy is? This is William Stewart Halstead, considered the father of American surgery. He was also the first captain of the first 11-man football team at Yale. And one of the big four, you know, we talk about these basketball super teams. The first super team in medicine was Johns Hopkins, the big four. He's one of the big four founders of Hopkins. And he actually was a pioneer in nerve blocks. So he was using cocaine in the late 1800s for nerve blocks. And occipital nerve blocks are finally coming into this realm where neurologists and physiologists and physiatrists are performing these as temporary measures or temporary ways to alleviate headache, maybe a good option for the post-operative patient because it can give you some immediate relief. He later did develop a cocaine addiction, and he's actually, the interesting story is he was brought into Hopkins not only because he was famous, but William Welch, who was the first dean of the medical school, he was a good buddy and he just wanted to keep an eye out on him for his cocaine use. So going to tolerability again, you know, these meds are very difficult. If you or your spouse had migraine headaches and you had to put them on medications that's going to make you gain 40 pounds, lose your hair, develop kidney stones, make you dizzy, and make you irritable, I mean, what would you say to that? That's not very appealing to patients. So we get into the next question here. So which statement is false about Botox? All right. So it's only indicated for chronic migraine. However, we are using it in practice for cluster headaches as well, as we kind of talked about some similar physiology. And so, and the funny thing is that this not only looks like my mother-in-law, but it looks like my former mother-in-law as well. So, it's just amazing how this. So botulinum toxin has been around for almost 40 years now. So it's developed for ocular motor dysfunction. Then all these patients started coming back saying, hey, my headaches are better. It is FDA approved as of the last 5 years, so it's not completely new. The injections are very simple, injecting on the frontal areas, temporal areas, the occiput, and the trapezii. And if you ask, well, how does botulinum toxin work? It doesn't work by weakening the muscles, which is why we normally use Botox for cervical dystonias and ocular motor dysfunction. We think it actually works by stopping that initial trigeminal nerve activation of the inflammatory cascade. So it is an external therapy that seems to help with migraine, but it doesn't help with episodic migraine. This suggests that there is a difference in terms of the number of headaches that you have and how the headache signal or headache cascade is propagated. One of the interesting attempts at new therapy was this acuity patch by Teva. It's not a transdermal patch, it's an ion transport patch. So there's actually a battery, you activate it by rubbing your fingers around the end of these batteries, and it uses an ion transport to transmit sumatriptan, but it was taken off the market after people started getting burns on their arm. So it's a very interesting idea, didn't work for migraine here. So now we get to stimulators, which is kind of half my new therapeutic talk, okay? So some of you are familiar with this, the occipital nerve stimulator. When I was in fellowship, this was kind of the hot new thing, and we were very excited about it. Some of the studies showed that up to 6 years, you might get a 40% benefit, 40% of patients getting greater than 50% reduction in their migraine. However, complications, up to 40% of these patients had to get revisions of their stimulator, very difficult to get approved, it was a therapy that we mainly aimed at the refractory patient, the person who did not respond to anything. And so this was the worst of the worst. And so if you're saying that at 6 years you got 40%, that's pretty darn good to me. But it really has kind of fallen out of favor, mainly due to getting this authorized. So, you know, for the last 5 years, we've had a therapy called cephaly, and I've been describing it as Wonder Woman's headband here, and then he came out with a smoothie. So the cephaly device, you know, we smuggled in from Canada about 3 years before FDA approval, and we've been using it, don't tell anyone. We've been using it on our patients, and it's a supraorbital stimulator. So it is a device where you put a sticky patch and attach this device to your forehead. You push the button, and it sends an electrical stimulation to the head. The initial concept was that would it directly mitigate a nerve impulse that initiates this migraine cascade. Hasn't really worked very well in the abortive region, but in some studies, showing up to 40% with episodic migraines, so people who had anywhere between 2 migraines up to 14 migraines in a month, and people with chronic migraine, people with 15 migraines a month or more, up to 35%. Now, we don't necessarily see that in our patient population. The last study was very recent in Italy, and all their study numbers seem to come out really well, or better than we see in the US. But we do see a benefit, maybe on average in the chronic migraine patient, 2 to 3 headache days, headache-free days a month, and some reduction in the severity. Doesn't work for everyone. Some people will put this thing on and say, it's shocking my brain. That's why we try it in the office first. But it is a therapy out there, something that does have some efficacy. Some of you, I don't know if anyone here in this audience has participated in the trials for the sphenopalatine ganglion stimulator. So it's a small device that's put up here, right under the maxilla, and it's being utilized for chronic cluster headache. And when you look at these numbers, so 10 patients out of 33 had a response, and you say, well, that's not very good, but again, this is the worst of the worst. These are the patients who have not responded to any medication therapy. And out of my 30-some-odd chronic intractable cluster patients, I'll take 10 wins. So remission periods could go up from anywhere from about a month to up to almost a year in these studies. And if we look at the physiology here, and if you look at this anatomical slide, what do you notice about, let's see, you see that right there? Sphenopalatine ganglion. So, but where do you see the signal go? The signal's going to the vessels. So is this an area, or we believe that this is a nerve that helps trigger a headache process. So not only for cluster headache, but could this also be there for migraine headache as well? We do nasal sprays such as intranasal lidocaine. We do sphenopalatine blocks for some of these patients. And now we have a stimulator that may benefit patients. And how it works is basically the stimulator is implanted, and when you have a headache, you kind of dial this thing up, and you activate the system, and it stimulates that nerve to try to abort the headache, but done on a frequent basis can prevent cluster. This is a very interesting idea. This is from a company called Therapies out of Israel. And it's C-fiber stimulation. So this device is, again, a dial-me-up device. You wear this patch on your arm, and when you have migraine, you activate it by your cell phone, and it basically induces pain in your arm. And this is the old adage, you got a headache, what do you do to that patient? You punch them in the arm, and they don't think about their headache anymore. And so it actually stimulates the C fibers and activates descending anesthesia here. So let's go to another question here. Transcranial magnetic stimulators treat depression, have minimal side effects, are used for abortive and preventive therapy of migraine, or all of the above. correct. So the old device, so when I was in residency, this is what I was introduced to. It was a device that the psychiatrists were using for depression. Kind of an external way, emitting a magnetic impulse. The idea is sending this magnetic signal and basically kind of shocking the brain, if you will, to make them happy. But this was also being used at the time for some intractable head and face pain issues. However, the device was bulky, it was a large device, it was not very affordable, and patients had to come in, which is not a very practical abstract for headache patients. So they came out with this, and this is called the transcranial magnetic stimulator. It is a portable device. I don't know if anyone's ever seen one of these devices, but we actually have one, and we were actually one of the first 10 clinics to have one in the United States. So it's a device that you hold. It looks like the ejection pack of a jet plane. You push the button, it sends this magnetic impulse, and the theory is that that magnetic impulse will come down and knock out that headache signal of cortical spreading depression that we saw earlier. Very interesting concept. This is the kind of numbers we do see. We see somewhere around 40–50% benefit in our patients. Again, we are using them in the medication refractory patients, so kind of the worser case patients. Should they be used in earlier stages? So if you are a practicing surgeon and you don't want to be on topiramate, could this device help you avoid the headache, help you prevent headache, and yet not give you the side effects? We've actually studied this in pregnant patients, a small N of 3, but I've actually used it on one of my pregnant patients as well. Safe, there's no real concern at this stage. So although it's safe, it poses an issue with costs, about $250 a month to rent the device. A new device is also coming out called a vagal nerve stimulator, and this is being indicated for cluster headache. So again, another vibrating device that you hold along your clavicle and your anterior neck on the right side. It sends an electrical stimulation, and the idea is, can you stimulate that vagus nerve and cancel out a headache signal? A lot of you know VNS as for epilepsy. You know, one of the most famed neurologists to come out of the state of Colorado, a guy named William Lennox, Lennox-Gastaut syndrome. He postulated 100 years ago that migraines and epilepsy are sister disorders. And like sister disorders, we see a lot of anti-epileptics being used in headache disorders. And in this, it's being used right now for cluster headache. They are trying it out for migraine headache, but it doesn't seem to work in the chronic cluster patient population. And this is one of the studies that were shown. So Act 1 showed about 34% of patients showed a 50% reduction in their pain, and Act 2 showed a slightly higher percentage, 47%. All right, so we're going to get to serotonin agonists. Some of you in the audience may have tried a triptan before, something like Imitrex or Relpax, these therapies. A new therapy is coming out that affects the 5-HT1F. So the old therapies affect 5-HT1B and D, and these are found in the vascular system. So the big warning sign, or the big warning issue with a medication like triptan is don't use it if you have peripheral vascular disease, if you've had stroke, if you've had a heart attack before, although we still see patients who come in on triptan, because there's this risk of vasoconstriction. Okay? So this bypasses this whole system and goes really right to the brainstem. So it's called lasmitan, and it's from Lilly, and it shows fairly good response, 30 to 40% response in the 200 milligram doses. This is the most recent study, the Samurai study. They've done 3 studies. They were called Spartan, Gladiator, and Samurai. Don't ask me how they got these acronyms to work for their studies, but this just came out last month, showing very good results in terms of efficacy, as good or better than the numbers that we see for triptans. But more importantly, look here, vascular safety. So it was fairly comparable to placebo. So your older patients, your mother who is 65, who's got migraines, who gets benefit from sumatriptan, that's an age where we want to start getting off these medications for vascular risk. Could this therapy replace that? All right, so another question. What is CGRP? Stands for calcium gene receptor peptide. Is a lettering on the side of Soviet-era submarines. Works as a vasoconstrictor. Is found in the central and peripheral nervous system. So CGRP is actually found in the central and peripheral nervous system. It stands for calcitonin gene-related peptide. And so I remember doing a topic in residency where we were doing a journal club, and we discussed a paper back in 2004 about CGRP. And since then, I've been like Linus out in the pumpkin patch. It's coming next year. It's coming next year. After a while, the initial studies showed some liver toxicity. They withdrew it from the market. We thought it was dead. And then one of my patients said, hey, did you realize that they're doing research on CGRP again? I had to look that up. Found out they were. We actually built a research arm of our practice to get started on some of the studies. And they're coming next year. So what is CGRP? It is a protein, and if you remember that initial diagram that I showed of the trigeminal nerves that wrap around the external part, the extracranial part of the brain, and you saw those little inputs where they connect with, or where they touch the vascular tree. So CGRP is released from the ends of this trigeminal vascular system. It's seen elsewhere as well. It's seen in the GI tract. We're not quite sure what that does. It's seen in the central nervous system in terms of, we see it in the brainstem and the brain proper. But we really are focusing on this extracranial component that we feel may be a very interesting site for prevention of migraine. So, again, we talked about it being in the brain, the brainstem, the dura, and the trigeminal ganglion. So, the CGRP abortive. So this was the first medication that was being studied, a few years back. It was by Merck, and what they were using it for was as a prevention strategy. This is the small molecule. This is a CGRP blocker, so a medication that you would take orally, and it would go to block this protein, conceivably to stop this initiating cascade of the migraine process. This is the one that caused liver toxicity. Now, Allergan has taken this back up, and we've been part of the research trials on this drug as an abortive. So, again, we talked about older patients, vascular patients, patients who can't tolerate the triptans. Is there an alternative for these patients to take? This is one of those alternatives. Can these patients take this small molecule, which is how we're categorizing this line of medication, and use it as an abortive? Numbers seem good, but again, look at this. The side effects are almost consistent with placebo thus far. And that's the phase 2b trial. We're in the phase 3 trials now. But then we get to something very interesting, is the CGRP preventive therapies. All right, so the next question, drugs that end in MOB for 1,000, Alex? All right, the antibody drug name that is human, 100% human. Is it OMOB, ZUMOB, UMOB, or ZMOB? right, so in the prior discussion, you heard about cancer agents that end in MOB, right? So let's talk a little bit about it. This is the real hot area in pharmacological research right now. Antibodies for various medical issues, and in this case, headache disorders. So how do they work? Now, when we think about this, and I want you to take a look at this, you remember the arms here that go up. This is the variable site. These change, and these determine what the antibody attacks. The tail end, or the body part, stays consistent. And in the indirect treatment, for instance, in chemotherapy, these antibodies go target the cancer cell, wrap their arms around it, and the tail calls in the killer cells to kill that cell. So that's an indirect method of antibodies working. Well, what about direct? If there's an indirect, there must be direct. So the direct method is that these antibodies find their site and either deactivate their protein or block the receptor. And that's how these new drugs are working. And so we're going to be talking about mainly, there's one human and 3 humanized drugs. So these are the 4 companies that are doing these studies. The Amgen product is a completely human drug. The other 3 are humanized, meaning over 90% human. Does it really matter? There's some theoretical questions about whether or not it leads to other immune cross-reactivity or issues down the line. But all these drugs are coming up all next year, okay? They're all being studied at the same time, and they've actually helped us change some of our paradigms in terms of how we think about migraine and actually how they study migraine. So one of the constructs that has changed a little bit is accepting this idea of the non-responder. So we, in clinical practice, will see patients that don't seem to respond to any medication, no matter what we put at them. Even the strongest therapies that theoretically should be responsive to, there are some patients that absolutely don't respond to meds. And we have adopted this as part of the research paradigm with these drugs. And we do see the, quote, non-responsive patients, period. But then, conversely, we see a new category of individuals who are super responders. They take one dose, they're greater than 75% better, and even in a handful of these studies, 100% better at 3 months. So I'm going to try not to be biased. I've participated in a lot of these studies. I'm just going to pull components of the various drugs, but I would rather have you think about these drugs as an entire family or category, because we won't know how well they actually work until I go home and experiment on my wife. So, we're going to have to wait and see until it hits the market and we actually see it in the main population. So this is ebenezumab. This is a therapy that is an IV infusion, and it's 1 IV infusion every 3 months. These are large molecules and they don't cross the blood-brain barrier. That's another important point. But I just want you to look at the second point here. So this is the PROMISE-1 study. Greater than 50% reduction on day 1 post-dose. So you're not waiting 4 weeks. You're not waiting 6 weeks. You're seeing benefits 24 hours after infusion. And again, I want you to think about this as a category that this part was published. And then again, the super response, 75% of people who have had 75% response, 1/3 of those patients achieved that weeks 4 through 12. So this was done for episodic migraine, patients with migraine anywhere between 4 to 14 a month. But getting 75% improvement, and there was, if you look at the line just down from there, 1 in 5 patients had 100% response at that period of time. We dare not use the term cure, but the numbers look very, very good. I was waiting for this slide, and I didn't want to put the Regain study here, and this is the Lilly drug. I actually wanted to put their cluster headache data. So 2 of these companies are trying to get FDA approval for cluster headache indication. It's very promising at this stage. But you know, the Lilly drug also shows very good response, reduction of headache on average about 5 for that headache group of 4 to that headache group between 4 and 14 headaches per month. So 5 in a month, pretty significant. The Halo 3 trial, this is the Teva trial. And so this is a very interesting drug. So it's a subcutaneous injection that's lasting 3 months in duration. So this is also going for a cluster headache. So it's quarterly in reduction of 4.3 headache days per month. And then Amgen's product, which will probably be the first one out. This is a very interesting trial that just came out showing safety. And again, we talk about those vascular patients again, those patients who are getting endovascular procedures and such. Is there a way that we can treat these individuals and not have a vascular response? Very interesting study. They took patients with angina, put them on treadmill, and half of them got the drug, and they waited to see if someone had adverse reaction. And it's very clever, but there was no difference from the placebo group. In fact, that group actually did a little bit better. So the safety, I've not seen safety numbers like this in anything that we talk about in neurology. So it's very, very promising in this field. So what are the implications in the future? What about traumatic headaches? You saw data that seemed to suggest that within 24, 48 hours, patients got better. Are we going to be using them for athletes? Question mark. Vascular patients, we had an endovascular discussion earlier. What do you do about those patients who have postoperative headaches? And then the chronic narcotic patients, which we also discussed earlier today. You know, one of the things that we did not see put up was anything about opiates, tramadol, acetaminophen, or butalbital, because none of those therapies really work in migraine therapy, and we try to avoid those therapies. In these studies, we saw a significant reduction in narcotic use in these patients. So thank you for your attention today. I'm happy to answer any questions that you may have. Thank you again.